Hi, I'm Cindy Rapp. I'm a sonographer from Denver, Colorado, and today I'm going to be talking about advanced breast ultrasound. We're going to cover intraductal lesions and sonography of implants. We're going to be talking about advanced breast ultrasound today, particularly looking at intraductal lesions and sonography of implants. Looking at breast anatomy, basically there's 15 to 20 lobes within the breast. These are a varying size of ducts and lobules. They're surrounded by connective tissue, and each lobule has approximately 30 ductules or acini in each of them. The ducts of the breast can be very tortuous, so later on in this lecture I'll show you some different maneuvers that can be done to help straighten out the tortuosity of the ducts that we run into in breast ultrasound. Imaging evaluation of nipple discharge. Mammography is seldom helpful in evaluating nipple discharge. Galactography is considered the gold standard, but the role of ultrasound is still expanding, and we are going to define it a little bit better today. When we image patients for nipple discharge, galactography typically is reserved for our high-risk patients. So high-risk patients are those that are considered to have spontaneous expression of the secretions, typically only from one side, coming from a single duct orifice. The discharge color should either be clear, serous, serosanguinous, or bloody. More low risk that we tend to use ultrasound for is when the secretions are expressible only, if they are bilateral, if they come from multiple duct orifices, or if the discharge is greenish or milky. And in looking at these different discharges that can come from the nipple, here is what the clear would typically appear to be: serous, serosanguinous, and frankly bloody type discharge. The low-risk type ones that we will see are as if they're greeny or an actual milky discharge, and other types that occasionally can occur, more of an indeterminate, is when we get this comedo or more of a cheesy type of appearance of the nipple discharge. Now, the use of ultrasound when we evaluate patients with nipple discharge, if galactography is suboptimal or if it fails, sometimes you could actually get a keratin plug that obstructs the duct, and so you cannot get any nipple discharge. Occasionally you can have unsuccessful cannulation of the duct. Extravasation of contrast behind the nipple can possibly occur. The duct can be so large or filled with so much contrast that it will actually obscure the lesion. And I'm sure none of you have ever cannulated the wrong duct, but occasionally the wrong duct can actually be cannulated when evaluating patients with ductal ectasia. So here's an example of when a galactogram had failure. You can see that there is extravasation of the contrast within this duct, so we went ahead and did ultrasound. Patient had presented with bloody nipple discharge, and what we can see is a little bit of ductal ectasia here and this intraductal papillary lesion. So ultrasound was able to definitely give us the answer that we needed in evaluating this patient with nipple discharge. Here's another example of a patient with a galactogram that we had a failure of. There was just too much contrast, it was too dense. With ultrasound in evaluating this patient, you can see that there are multiple ducts with fluid in them, and you can see that we've got papillomas in multiple locations. So ultrasound once again was very helpful in evaluating this patient that presented with abnormal nipple discharge. This is a patient, when doing the galactogram, everything was perfectly normal. So we went ahead and took a look with ultrasound and actually found there was a separate duct, that there was ductal ectasia, and an intraductal papillary lesion was seen within that duct. So ultrasound was very helpful in evaluating the patient where the wrong duct was cannulated. Now, a lot of people think that intraductal papillomas are echogenic. They really are not echogenic. If you do see something that you believe is an intraductal papillary lesion and it is echogenic or the same echogenicity as the fibroglandular tissue, actually what you're getting is just an area where the duct courses off to the side, and this is a pseudomass. You can see when we rotate 90 degrees, what we're picking up is just this band of fibrous tissue sitting between these two different ducts here. Actual intraductal papillomas are not echogenic, they are isoechoic. In other words, they are the same echogenicity as fat. If you notice, the normal wall of the duct that we can see right along here is echogenic, and intraductal papillomas tend to be more isoechoic or same echogenicity as the surrounding fat. So this is looking at a long axis view of a duct with ductal ectasia, an intraductal papilloma, rotating 90 degrees and getting a short axis view of also that same intraductal papillary lesion. Just showing you another example, here's a patient with a fairly long intraductal papillary lesion. You can see the wall of the duct is echogenic and the papilloma itself is isoechoic. This is long axis view. Here is also a short axis view showing you the echogenic wall and the isoechoic papilloma. Now often ultrasound can show you the extent of the lesion better than the galactogram does. Here you can see, we can see a filling defect on galactography. Looking on ultrasound, we can actually see this very long intraductal papillary lesion. So we can often see the extent of the lesion better with sonography than we do galactography. Now, what we want to make sure when we're imaging patients with nipple discharge, we want to make sure that we see the entire duct to the orifice on the nipple. When we scan, we want to try and keep a warm room, and having warm ultrasound equipment, usually this is not that hard to do. They put out quite a few BTUs. Use warm gel, and then we scan in a radial and anti-radial scan plane. We talked about special maneuvers that we can do to be able to see the ducts better, and we'll cover those. In doing these special maneuvers, we're able to visualize the ducts that are subareolar, and even ducts that can lie within, or I'm sorry, lesions that can lie within the nipple. We can see those much better in doing these maneuvers. Now what happens when we image the nipple itself, if we look at the way the ducts run in the nipple, we get sort of a 90-degree angle between the ultrasound beam and the segment of the ducts. Different maneuvers that we can do a peripheral compression, we'll go over each of these individually, two-handed compression, and also a rolled nipple technique. And typically we will use that for evaluating the actual ducts inside of the nipple. So looking at this diagram of the nipple, you can see one reason that if you scan straight over the nipple, you get intense shadowing. All of the ducts are actually running straight up towards the ultrasound beam. On ultrasound, we see structures that are parallel to the transducer face much better than we do ones that are perpendicular to it. So if we scan directly over the nipple, majority of time we get intense shadowing and cannot see anything retroareolar. So we'll cover these different maneuvers that can be done. So this is scanning a straight anterior-posterior approach. This is a patient that presented with abnormal nipple discharge. You can see that there is some ductal ectasia here, but we just get intense shadowing behind the nipple when we do scan in a straight anterior-posterior approach. Now doing a peripheral compression, what we do is take the transducer and just sort of push on the side of the nipple, lay the nipple down. You can see we're seeing a little bit more of the ductal ectasia, but we actually are still getting shadowing directly behind the nipple. Now doing a two-handed compression, this is one technique that I use quite a bit just to straighten out the ducts when you're evaluating them. I'll take my free hand, push it up on the edge of the breast, take the transducer on the opposite side of the breast and just sort of compress. And then you scan around the breast that way. So if you're pushing from the 3 o'clock side, your transducer will be on the 9 o'clock side. If you're pushing from the 12 o'clock side, your transducer will be at the 6 o'clock side. Just sort of work your way around the breast looking for ductal ectasia. Once you find an ectatic duct, then we're looking for the lesion that possibly could be within that ductal system. The rolled nipple technique is what is very helpful for evaluating the ducts actually inside of the nipple. What you do is you take your index finger, lay it right up on the side of the patient's nipple, take your transducer, sort of roll the nipple up over your finger. In fact, on this image here, this is my index finger. This is the patient's nipple, and then you can see a normal duct extending all the way through to the very edge of the nipple. One thing that you need to make sure you do is use a lot of gel for evaluating the nipple, just to make sure that you don't get any air artifacts when you do this type of scanning. Now here's a patient when we scan directly over the nipple. You can see we've got a big gel standoff here. This is scanning sort of straight AP on the nipple in an anterior view. And we're questioning if there is a papillary lesion within the nipple. But you can see by doing a rolled nipple technique, here's my index finger located right in this area. This is scanning directly up over the nipple. You can see the ductal ectasia coming all the way down. There is one intraductal papillary lesion here and a fairly long lesion extending all the way through here. So we can actually see the adenoma within the nipple and this very long one by doing this rolled nipple technique. Here was a patient that we scanned. You can see this is scanning directly through the nipple. We can definitely see that there is one intraductal papillary lesion in this area, and we had a question as to whether there was a second lesion right in this area. Now remember, I did tell you that intraductal papillomas are not echogenic, they are isoechoic. But in doing the rolled nipple technique, what we were able to see is this is only a single lesion here. This is one ectatic duct, another ectatic duct sitting right here, and actually what we were seeing was the space or the wall between those two ectatic ducts, and it was not a second intraductal papillary lesion, there was only one. We can also look and see the extent of the papilloma into the nipple. You can see in doing the rolled nipple technique, we can see the papilloma right here. This is scanning straight AP. You can just see that we're not able to visualize very well. And then just sort of doing a elongated image through here, we can see the extent of that papillary lesion throughout the nipple. This was another patient that presented with bloody nipple discharge. We scanned completely around, did not really see much ductal ectasia, but then went ahead and did the rolled nipple technique, and we can see what the patient has is a true papilloma lying just in the nipple only. There was no other ductal ectasia. She had presented with bloody nipple discharge, but here you can see the long axis view, index finger through here. This is the entire nipple, the ductal ectasia, the papilloma, and then rotating 90 degrees and getting a short axis view of the papilloma inside of the nipple. Sometimes you may have echogenic secretions that can sort of mimic intraductal papillary lesions. So this is just thick secretions within here, whereas this is a true sort of more of a papillary lesion that we can see. Now, one thing that can be helpful if you do have a patient that has thick secretions, you can actually do some ballottement. So if you take your transducer and compress down, you'll be able to see the fluid sort of moving back and forth, so very helpful in evaluating that. If we look at this patient here, we have a fluid debris level, and we were questioning that versus looking at a true intraductal papilloma. The fluid debris level, you typically have a straight line going across, whereas a true papillary lesion, you can see it sort of rounded on the ends. Now, what's very helpful to evaluate these is by doing the ballottement mover, so compressing down, releasing your pressure, and you'll be able to see the fluid move back and forth. So you can see sort of elongation of this. This was just thick secretions that we can see within that patient with ductal ectasia. In looking at that, and the secretions were mobile when we did the ballottement. You can turn color Doppler on, and as you compress down, you can get the fluid to move one direction. When you move the other way, you can see that the fluid comes back. So this was actually with compression, fluid moved down the duct. As we released the pressure, the fluid came back up through the duct. So it's something that we actually typically will just watch in real time and don't often use color Doppler, but you can see the secretions moving back and forth as you are doing your compression. Color Doppler can also be very helpful to evaluate a fibrovascular stalk. Papillomas tend to have quite a bit of flow within them, and typically a normal single vessel feeding them. So here is a short axis view that we can see this fat fibrovascular stalk feeding the papilloma. If you notice, there is some ductal ectasia here, but this is just some thick secretions. There was no flow located in that area on that particular patient. Now, looking at inspissated echogenic secretions versus a papilloma, if you use light pressure, sometimes you can see that there is sort of fluid moving back and forth with the echogenic secretions, whereas with the true papillary lesion, we get a vessel coursing through the middle of it. So this is an intraductal papilloma. This was just thick secretions, and by applying pressure, you can sort of get the color swoosh that you can see with that. Now, one thing to be aware of, papillomas can undergo hemorrhagic infarction, and so sometimes you may not see Doppler flow if they have infarcted. If you try your ballottement and you don't see the fluid moving back and forth, and it sort of is a fixed structure, but you don't pick up any flow, it possibly could be an infarction of the vascular stalk of that papilloma. Now, multiple central papillomas are more commonly seen sonographically than they are on galactogram. And here we can see different ducts that we can see the papillomas in. So ultrasound is fairly easy to pick up when a patient does have ductal ectasia, and imaging in multiple planes, we can pick up these multiple papillomas in there. If they happen to lie in a different ductal system that was not cannulated for the ductogram, you can see how those could easily be missed on the galactogram. This is also showing you these multiple papillomas and the fibrovascular stalks that we can see within them. So once again, color Doppler can be very helpful for picking these up if we do detect the fibrovascular stalk. Now, when I start to scan a patient that comes in with abnormal nipple discharge, as a sonographer, I typically do not have them express any of the secretions when I start my imaging. If I have them express the secretions and then the radiologist comes in to try and do the galactogram, sometimes all the secretions have already been expressed from doing the ultrasound, so I tend to have them wait to expressing the secretions when they're going to do the galactogram. But what I'll do is ask them if they know what portion of the nipple that the secretions typically come out of, if it's at the 12 o'clock, 3 o'clock, 6 or 9 o'clock. And if they can't really tell, then I sort of scan with my transducer in a radial scan plane with it halfway on the nipple and sort of in the soft tissue surrounding it, and then just sort of work my way around looking for ductal ectasia. Once I find an ectatic duct, I will just sort of sweep that area back and forth in longitudinal. Then I rotate my transducer 90 degrees to sort of the anti-radial or radial scan plane and evaluate it that way. And then just continue looking all the way around for any more ducts that might have ductal ectasia within them. Now, there's several different factors affecting the appearance that we will see of intraductal papillary lesions with ultrasound. You may have presence of ductal dilatation. So if you look at these, it's fairly easy to see the papilloma if there is ductal dilatation. Sometimes you may have the papilloma just obstructing the proximal portion of the duct. You may have it branching into multiple ducts. You can have very large papillomas extending the entire length and even branching into it. Sometimes you may have them forming into branching ducts. You can have them in a cyst. And then you can have cases where it actually doesn't even involve any ductal ectasia, but you may see a little bit of duct extension or branch pattern coming off of these different papillomas, but many appearances that we can see sonographically of these intraductal papillary lesions. So the spectrum of appearances that we'll see with these large duct papillomas, here's just an example of a small oval nodule that we can see ductal ectasia both proximal and distal to it. Here's a small oval nodule that we can see there's only ductal ectasia proximal to the lesion. This is a fairly long papilloma extending into two different branches of the ducts. This is a long papilloma that just fills the entire central duct. It's not branching. And here's just another very large one that is branching also into multiple ducts of that papilloma. Now, these are all papillomas without ductal ectasia. Here is one that can just be presented sort of as round or oval. This is one that is microlobulated. This is a papilloma that we can see just an area of duct extension. This is another intraductal papillary lesion that we can see a branch pattern coming off. And then sometimes we can get a lazy Y appearance of the nodule with ductal extension into that or the branch pattern that can be seen. This is looking at isolated, sort of just minimal duct extension or ductal ectasia, not coming from the nipple, but here you can see the papilloma within it. We may see intracystic papillary lesions and intracystic papillary lesions where it actually extends into the duct and then also into the cyst. So these are all sonographic or different sonographic appearances that we can see with these intraductal papillary lesions. The diameter of the intraductal papillary lesion does affect its ultrasound appearance. You can see here's a very large ectatic duct and a fairly small intraductal papillary lesion. These are ones that fill the lumen but do not expand it. And here's a very large intraductal papillary lesion that actually expands the size of the duct. So these are all different sonographic appearances that we can see. Intraductal papillary lesions tend to have a very high water content. And so what we typically will see with a lot of these is enhanced sound or through transmission behind these large papillary lesions, just because the amount of water content that they have within them. Intraductal papillary lesions are also fairly soft. So if you scan with heavy pressure, a lot of times you can compress them. Beware though, if you're looking for the presence of a fibrovascular stalk, you need to make sure you scan with fairly light pressure, because compressing them, you may actually temporarily ablate the flow and not be able to pick up your Doppler signal. Now there are several etiologies for nipple discharge. You could have a benign intraductal papilloma. There could be carcinoma or DCIS or invasion in DCIS. You may have atypical ductal hyperplasia. You may have just some ductal ectasia, possibly a communicating cyst, and sometimes it's just idiopathic. We can't really tell why the patient presents with nipple discharge. But this is a patient that came in. You can see on the right side, there's just a normal small duct here. She presented with nipple discharge, and all we could see is just ductal ectasia that was causing this patient's nipple discharge on the left side. Now, duct ectasia that causes nipple discharge, there can be different echogenicities of the secretions. Sometimes they may present as almost anechoic. They may have some low-level echoes within them, and sometimes they may be fairly echogenic. But just to make sure that these are not true papillary lesions or intraductal papillary lesions, doing your ballottement is very helpful in actually seeing this fluid swoosh back and forth, both anytime you see any type of low-level echoes within those papillary or intraductal lesions. Now, when we have a patient that presents with chronic nipple discharge and you see severe bilateral ductal ectasia, we need to think of hyperprolactinemia. But this is scanning retroareolar on the right side and the left side, and you can just see that there is chronic ductal ectasia. There's low-level echoes within it, and this was a patient that did have hyperprolactinemia. Now, ductal ectasia that causes nipple discharge, sometimes a patient may have a little bit of pain and have some acute periductal mastitis. The normal walls of a duct are thin and echogenic, but when a patient gets inflammation of the duct, you can actually see the walls become thick and isoechoic. This is the same sonographic appearance that we see in cyst. A normal cyst wall is thin and echogenic, and when a cyst becomes inflamed, the walls become thick and isoechoic. Color Doppler can also be helpful in evaluating the patient with acute periductal mastitis. But here's a patient that was having bloody nipple discharge. You can see all this echogenic secretions. This was all hemorrhage inside of the disc in the duct. Putting on color Doppler, you can see the hyperemia that we can see within this. In a long axis view, rotating 90 degrees, you can see the short axis view of that hyperemia within this patient having periductal mastitis. Just another short axis view looking at the bleeding duct. If you notice there's a normal duct sitting adjacent to it, notice there's no hyperemia within this duct. This is the duct that has the periductal mastitis, and you can just see the amount of hyperemia within that duct wall. And on galactogram, once again, you can see the same area on the ductogram showing you that periductal mastitis. Now, when we use color Doppler, there's one way to tell the difference between infection and a true papillary lesion. Hyperemia will be in the wall, so it's going to be more on the outside or parallel to the duct wall. Whereas if you have a true intraductal papillary lesion, the flow is going to be located central, so it's going to be perpendicular to the duct wall. So this is just an intraductal papilloma, and you can see the blood vessels coursing right through the center, whereas when we have an inflammation, it's going to be more in the wall and parallel to the duct wall. Communicating cysts can cause nipple discharge. This is sort of a trigger point. You have to be careful because if you take your transducer and compress down on either of these communicating cysts, you may actually get quite a bit of ductal ectasia or nipple secretions to express directly through that area there. This is another patient that we can see communicating cysts causing nipple discharge, sort of the trigger point. As we compress on the cyst, you can see that we got the flow to move one direction. When we released the compression, we actually saw that the flow came back. So that's just using color Doppler to show that trigger point on it. These are also communicating cysts causing nipple discharge. You can see all of this ductal ectasia and all these different cysts that actually communicate with that duct, and this was present in a patient that did present with nipple discharge. Now, ultrasound-guided percutaneous galactography, if you cannot cannulate the duct when the patient comes in, you can use ultrasound to actually put a needle in here and do the ductogram if there is a failure, you cannot cannulate the duct. So ultrasound can be very helpful. If ultrasound can be used, if you cannot cannulate the duct, you can take a needle and apply it right here into the duct, fill it with the fluid, and then be able to evaluate the ductal ectasia fairly well if you do have failure of cannulation of that duct. And here's just the example. You can see the needle coming in directly into the duct, so ultrasound guidance can be very helpful. If you're even going to surgery and need to inject a blue dye, you can do that with ultrasound guidance using the needle. Now, intraductal papillary lesions, the risk of malignancy or atypia, so basically if there's a greater than 2% risk, so anything that we consider to be considered more like a BI-RADS 4A, is anytime you have the presence of any hard findings. In other words, anything suspicious for malignancy, such as angular margins. Anytime you have the soft findings, such as calcifications. If the intraductal papillary lesion expands the duct more than the amount of fluid does, anytime the intraductal papillary lesion is longer than 2 centimeters, if it involves any type of branching, or anytime it involves the terminal ductal lobular unit. All of these are at greater risk and definitely should be biopsied. So this is showing you an intraductal papillary lesion. You can see the normal duct and the fluid. It is larger than the size of the duct. It also has angular margins extending throughout it. This is just showing you, here's the normal duct with the ductal ectasia, and you can see these angular margins coming off of it. And the papillary lesion is larger than the size of the amount of fluid inside of that duct. So these are definitely hard findings, the angular margins, larger than the size of the duct. This is sort of looking at the rolled nipple technique. You can see the duct right into the nipple and these hard findings within this papillary lesion. Here's another one looking at soft findings that are suspicious, so the presence of microcalcifications. Here you can see the duct. The lesion also extends greater than the amount of fluid inside that duct and microcalcifications within that. Once again, because of the high water content within these lesions, a lot of times you're going to see the enhanced through transmission posterior to these intraductal papillary lesions. On color Doppler, you can see there's quite a bit of blood flow also present in that. Not just the single vessel feeding it, but there's multiple branches that we can see feeding that, so not just a single vessel that we typically see with benign intraductal papillomas or papillary lesions. And this is looking at the ductogram of this patient. You can see how it extends beyond and actually fills that area through there. Intraductal papillary lesions that extend beyond the lumen of the duct we've talked about. So here's just a little bit of fluid in the duct. This is one that is worrisome that would definitely be given a BI-RADS 4 category if it's larger than the amount of fluid inside of the duct. So this is one suspicious. If you see an intraductal papillary lesion longer than 2 centimeters in size, or if it branches, these are also worrisome, so these should definitely be biopsied and looked at. Here's another one that we can see extensive branch pattern. This is a high-risk type appearance, but here's the intraductal papillary lesion branching through multiple different areas of that duct. Peripheral papillomas basically are any time you have a papilloma involving the terminal ductal lobular unit instead of the main duct. These are definitely at higher risk, and we're going to talk about those a little bit more. Peripheral papillomas involving the TDLUs far from the nipple. A lot of people think if it's a peripheral papilloma, it has to be ones that are the distance from the nipple, but that's not the case. A peripheral papilloma just means that it is a papilloma involving the TDLU itself. Notice the amount of flow that you can see within these peripheral papillomas also, more than just the single vessel sort of that we get feeding into the center of it, but these are peripheral papillomas. And peripheral papillomas also involving the TDLU right near the nipple. You can see it branching in, coming up through multiple TDLUs in this area through here. This is looking at another patient with both a peripheral and a central papilloma. So here is the main duct with the ductal ectasia. This is a central papilloma. We also see that there is a papilloma involving the TDLU. And we turned on color Doppler looking at these two lesions. Look at the difference in flow. With a central papilloma, we have the single vessel right in the center of it. With the peripheral papilloma, look at how much blood flow is present within those. So peripheral papillomas definitely are more worrisome than having one within the central duct itself. This is also just looking at peripheral papillomas, and once again, it refers to the origin within a TDLU, not the distance from the nipple. Here we can see the ductal ectasia, we can see a little bit of the duct coming down, and these are two papillomas that arose in TDLUs, so these are peripheral papillomas. Now we've talked enough about ducts, we're going to go ahead and move into talking about implants. A lot of people feel that implants should only be evaluated with MRI, and MRI is the best exam for evaluating patients with implants, but ultrasound can actually do a fairly decent job also if you kind of know exactly what to look for in these patients. Now if we look at the speed of ultrasound, basically if we scan through saline, the speed of ultrasound is approximately 1540 centimeters per second. In scanning silicone, the speed of sound through that is at about 970 centimeters per second. So what you're going to notice if a patient does not know if they have a saline versus a silicone implant, if you scan the patient in the upper outer quadrant where you get transducer with half of the implant on it and half of the pectoralis muscle, in a saline implant, you're going to see just a normal chest wall come across, but if you're scanning silicone, what you're going to see what looks like sort of a cutoff, and it looks like the muscle drops down, and that's just due to the speed of sound. So this is scanning a saline implant. You can see that the chest wall muscle comes straight across behind that saline. The speed of sound is approximately 1540. Whereas when we're scanning a patient with silicone implants, we have the chest wall coming along. As soon as we hit the silicone, it cuts it or slows that speed down, so it makes it look like there's a cutoff in the muscle right at that point. So that's one way that you can tell a difference if you're dealing with silicone versus saline implants, if the patient doesn't know exactly which ones they have. Now in looking at implants, you can have non-textured single lumen silicone gel or saline implants. What we're going to see on ultrasound is you're going to see the outer surface of the implant and the inner surface of the shell or the implant, and then the body's reaction to that is a fibrous capsule that we're going to see. So what we sort of call this appearance is the reverse Oreo cookie appearance, and so this is what we're going to be looking for in ultrasound if we're looking for the presence of an intracapsular rupture or disruption of the shell. So sort of if we take an Oreo cookie and invert it, it sort of is looking at what the shell is. This is the outer surface of the shell. This would be the inner surface of the shell. And this is what we're going to be looking for sonographically, is sort of this trilaminar of appearance on ultrasound. Now in looking at these textured single lumen silicone implants, once again we have the fibrous capsule. You can have the textured and then the implant wall or the shell that we'll see on sonography. You may have a fairly large textured single lumen implant, and there may be even thinner ones. So this is more of a classical type of appearance that we will see of the non-textured versus textured single lumen implants. So here's sort of scanning a patient. We can see this is the outer wall of the shell. This is the inner wall of the shell, which looks like the reversed Oreo cookie. And then the body's reaction to that implant, it builds up this fibrous barrier between that. So this is the trilaminar, or the three echogenic lines that we're looking for to see if there is an intact implant. Here's another example. You can see on this textured single lumen, this is the outer layer, the inner layer, and then the body's reaction to that we can see right along here also. You may have more of a textured implant. It's very common for us to see effusions along the edge of the implant, so we really don't get worried of that, but this is a textured implant. You can just sort of see that appearance of the shell and a little bit of effusion that we can pick up right through that area. Now, implants can either be subglandular or behind the pectoralis muscle, retropectoral, and in evaluating those, the pectoralis muscle actually gets fairly thinned when we take a look at that. But if you scan the pectoralis, you can see separation, sort of pectoralis major and minor, and looking to see if it is subglandular or retropectoral. Much easier to tell this on the mammogram. Here's one that we can see is subglandular, and here's one that we can see is retropectoral, because you can actually see the pectoralis muscle sort of splayed over the implant itself. So Mammography is very helpful in evaluating patients to tell if it is subglandular or retropectoral. So here's looking at a saline implant. This is the pectoralis muscle. We can see this is subglandular. And here's just a silicone implant where we get that cutoff of the pectoralis muscle. But once again, this is also a subglandular silicone and a subglandular saline implant, looking at these on ultrasound. Now, the diagnosis of capsular contracture is pretty much a clinical diagnosis. Once the patient lies down on their back, if the implant looks like they have a couple of baseballs sitting there, you know that they most likely are going to have capsular contracture. One thing that you'll note is with capsular contracture, you'll see bowing of the posterior wall of the implant versus a normal implant, you're going to sort of have this convexity to it. Now, if you also notice, anytime I'm trying to look at the complete posterior wall of the implant, you are going to need a lower frequency curved array transducer. If you're using your typical breast imaging transducer, high frequency linear array, a lot of times you cannot really see this. But once again, this is pretty much a clinical diagnosis, whether the patient has capsular contracture or not. Now, with capsular contracture, you are going to see a much thicker capsule on the patient. So here is the shell of the implant, this is the capsule, and just look at how thick that is. Instead of that thin echogenic line that we typically see, you will see a very thick capsule on patients with capsular contracture. You may also see calcifications. Here we can see the normal appearance of the implant, just a normal little calcification, a couple of calcifications. Now, if it becomes heavily calcified, you really can't evaluate the implant sonographically. As we all know, we're unable to visualize or see through the calcifications. So little calcifications like this really don't cause a problem, but if the entire implant has heavy calcifications, we just really cannot evaluate the shell of the implant at that. Now, other things that we can see, you may have partial collapse of the implant. We may see complete absence of the shell. You may see radial folds coming in within it. So we'll look at each of these sonographically. This is a patient where the shell is absent. So all we get is a single echogenic line. This is the capsule itself, but we don't see the shell. So this is an intracapsular rupture, and most likely the shell is down inside this part of it. But a lot of these patients, the silicone will stay sort of in that area, or you may have some extravasation. But this patient definitely has an intracapsular rupture. The only thing present is the very thin echogenic shell that we can see there. You may have partial collapse or separation of the shell from the capsule. So we notice in this area here, we have got the echogenic line of the capsule. Here is the shell, but yet we can also see a little bit of separation coming right through this area here. So in looking at these on ultrasound, you can pick up partial separation of the shell from the capsule. Now, beware that you can have reverberations in these, and you want to make sure. You can see we've got the shell here. This is the echogenic capsule on top of it. Here, where we can see just a single line of the echogenic capsule, this is a true intracapsular rupture or separation of it. This is a reverberation. Here we still have our 3 echogenic lines. This is only a single one, so this is showing you the difference between a true intracapsular rupture versus reverberation that we will get with ultrasound, just one of our artifacts that we have to deal with. This is another patient looking at intracapsular rupture of the left breast. Here we can see the thin echogenic line of the capsule in a radial and anti-radial scan plane, and then you get sort of this stepladder sign is the ultrasound term for intracapsular rupture. The Linguini sign is what is used for MRI. I kind of like the word Linguini sign better because it's kind of a food. I mean, I don't know why ultrasound has to call it a stepladder. I think it's better if we just call it sort of Linguini, but sonographically we do call it the stepladder sign when we see the intracapsular rupture. Now, very important, once you've seen a patient that has intracapsular rupture, or you're evaluating these are just sort of silicone granulations that we can see within this patient that has this intracapsular rupture, so different appearances that we can see in evaluating that. Once we see that, you kind of want to scan around the periphery. When we can tell that a patient has intracapsular rupture, then the key to what we're looking for is there any extravasation? But this is evaluating a patient with bilateral intracapsular rupture. You can see there's just the single thin echogenic line. We can actually see the shell partway through the breast in there. And then we're going to be looking for extravasation. Now, what does it look like if a patient ruptures a saline implant? You really don't need ultrasound to make that diagnosis. It is a clinical diagnosis, but this was a grandmother who had their grandchild sitting on their lap, and all of a sudden the little 2-year-old rammed his head back and actually fractured her implant that you can see here. And this is what it looks like on ultrasound. This is what the normal side looks like on the left. But once again, that's pretty much a clinical diagnosis. You don't need ultrasound to tell you if there is rupture of a saline implant. Now, in looking at implants, we can have radial folds that we may see within this, sort of a smooth shell. You can also get these little keyhole radial folds, and we still are going to see that echogenic fibrous capsule in looking at these patients. So this is seeing a radial fold. This is why it's very important when you see these to scan perpendicular to the fold and parallel to it, but this is just a radial fold that we're getting within the implant. So different things that we can see on ultrasound. These areas can be more prone to intracapsular rupture just because of sort of the bending of the implant through that area. Now, looking at radial fold versus sort of a normal wave appearance, this is a patient with a saline implant. They tend to be fairly easy to actually move these with the transducer and get this wave type of appearance versus a normal radial fold that we can see on these. So this is sort of coursing in right through this area here. So just the difference between a radial fold versus the normal wave appearance that we'll see. Now, if the patient comes in because they have a palpable lump, you know that they have implants, we go ahead and always scan them in the supine position. A lot of times what they feel or is palpable may only be present in the upright position. So this is a patient we did the ultrasound on. We can kind of see just this little area here, but really not palpate anything. Once we set the patient up, you can see that there's definitely this radial fold that appears. So it's very important to ask the patient if they come in with something palpable or if they think they feel something. Is it when they're sitting upright? Can they also feel it when they're lying down? But sometimes you do need to put them in different positions for evaluating patients with implants. Now, looking at these radial folds, the fluid can be completely anechoic within it. You may have echogenicity or echogenic fluid within it, and then at times may we actually get the snowstorm or the silicone granuloma appearance within this. So this is a radial fold scanning perpendicular and parallel to the fold. We can see that there is completely anechoic fluid within that area. This is one that we can see the echogenic fluid within it, and this is scanning another radial fold that we can actually see the silicone granuloma, that we get that polar bear in a snowstorm type of appearance in this patient with a radial fold. Patients can actually herniate through the capsule. Once again, this is a patient that presented with a palpable abnormality. They had a intracapsular rupture. This is the actual capsule coming across, and you can see this herniation of the implant sort of through that. So you may actually have herniation right through the capsule and not only through the shell. This is a patient also that had a palpable abnormality that was herniation of the implant, and scanning this at first, somebody thought that there was a cyst in this area, but when you actually elongate this out, this is the implant. Normally it should stop right at this area here, but this is just disruption of that capsule, and you can see herniation of the implant through the capsule. So make sure that you scan it in 2 different planes looking at it. This was an anti-radial, this was a radial scan, just showing you that herniation of the capsule through the shell. This is another patient that we can see a very large herniation of. This was intracapsular rupture. You can see that there is some silicone granulomas. The normal implant should come and end right along this area here, but you can see that there was disruption of the capsule and herniation of the implant. So when you would cosmetically look at the patient, you could definitely see that there was difference on the right breast compared to the left. Here's another patient that we can see sort of that echogenic fluid within it. The implant should come right along this area here, and you can see that there is herniation once again of the implant through the shell there, or through the capsule. Now, very common for patients with saline implants to present with a palpable lump. When they put these implants in, they try and put the fill port behind the nipple. Sometimes these may rotate a little bit, and it is a very common cause for patients coming in with a palpable lump. What you're going to see is the actual fill port, and then these are the little stays that they sort of hold the implant in place. But if it's not behind the nipple, this is very common to have a palpable lump in these patients that have fairly small breasts. So you can see that there's very thin tissue, so you can see how it's very easy for them to present with a palpable abnormality that is just the valve of a saline implant. So once we've evaluated someone to see if there's any disruption of the shell, we want to make sure and see if there's any extravasation of the silicone once we've evaluated them. So once we see intracapsular rupture, is there any silicone in the fluid or in the space adjacent to that implant? Now, if you scan directly over the center of implant, everything will look pretty good. This is a tissue anterior to it. We can even see deep to that. But really what you want to be able to do is scan all the way around the periphery. I think the most common location that we find extravasation is in the upper outer quadrants. So if I think I see echogenic fluid or the snowstorm appearance on a patient, I always like to do split screen comparisons. So this is a patient that has intracapsular rupture that we can see on this right side. This is extravasation of the silicone into the soft tissue. When we do a mirror image looking at the upper outer quadrant of the left, you can just see that there's normal soft tissue in this area and no extravasation of silicone on that left side. So kind of how I want to image that is put the transducer halfway on the implant, halfway on the soft tissue, and then just sort of scan all the way around the periphery, looking for any extravasation of the silicone. And as I mentioned earlier, most often it's going to be in this upper outer quadrant. You still definitely want to check all the way around the breast tissue also, but I think the most common location is going to be the upper outer quadrant. So here's a patient looking at the right side versus the left. You can see that there is extravasation of the silicone. This is not the upper outer quadrant. This is directly over a portion of the breast on that left that we can see the normal soft tissue. So this is what extravasation of silicone will appear. Now, extravasation of silicone in lymph nodes can also be present, that we'll see it. And once again, it sort of just has that dirty snowstorm appearance is what extravasation of silicone will look like. Now, this is a patient that came in, she had recently had implants put in. You can see this is actually her capsule through here. So this is the body's reaction to the implant. This is the shell, and then we saw this sort of echogenic area separating the capsule from the shell. We weren't sure exactly what we were dealing with. Was this a true lesion or what's going on? We asked her to come back 3 months later for a checkup. She did not come back for a 3-month follow-up. She came back a year later for her annual mammogram. And you can see this exact same area now within a year has gone to the classic snowstorm appearance that you will see with extravasation. So somehow when they put the implant in, they must have had a very small leak within it, and a little bit of that silicone bled out into the tissue separating the capsule from the shell, and you can see a year later how it's turned into this classic snowstorm appearance sonographically. Axillary lymph nodes, very important to look at anytime we see disruption of the shell from the capsule. We'll check the axilla. This is a lymph node with silicone extravasation into it, looking at it in a short axis and a long axis view. So in summary, ultrasound is effective as a first test for patients with nipple discharge. Ultrasound of ducts within the nipple and subareolar areas require special maneuvers such as the two-handed compression, peripheral compression, and rolled nipple techniques. Ultrasound can detect causes of discharge other than papillomas. The diagnosis of ductal ectasia requires caution. Papillary lesions are often associated with generalized duct ectasia, and sonography can play an important role in the evaluation of breast implants. Thank you for your time.